In the next couple of hours, we're going to be focusing on pediatric cardiac intensive care. And what I decided to do is divide the talk first about some preoperative issues and general cardiac intensive care concepts. Some of these things certainly will apply to the postoperative period as well. When putting my slides together, I looked at the American Board of Pediatrics content outline pretty carefully and looked at what the other speakers were assigned to talk about. So what we're going to do in this first 45 minutes or so is talk about low cardiac output syndromes, airway support, mechanical ventilation, some cardiopulmonary interactions, cardiopulmonary resuscitation, and some multi-organ system management issues if we have time. And in the second session, we're mainly going to focus on perioperative / postoperative issues and also the acute management of pulmonary hypertension. And then I just want to call your attention, I also submitted a study guide, which is a new thing that Dr. Armsby and the planning committee implemented this year that's 7 or 8 pages long, that's got some key tables and figures and a couple references that I thought you may find useful to review prior to the examination. So take a look at that on your own time if you get a chance. So before we start talking about low cardiac output syndromes, I wanted to just introduce some basic concepts regarding shock. And shock is a physiologic state of circulatory dysfunction or failure in which the delivery of oxygen and energy substrates is inadequate to meet the demands of the tissue and end organs. And shock can be progressive in nature. It can start out as a compensated state in which autoregulation of the different organ vascular beds kicks in to preserve end organ function. But if untreated, can progress to uncompensated shock in which there's microvascular perfusion is limited, metabolic acidosis develops, and if not reversed, you can end up with permanent end organ damage. So when thinking about shock, we need to appreciate these general relationships between oxygen delivery, oxygen extraction, and oxygen consumption. So if you look at the x-axis here, where we've got oxygen delivery, as shock progresses, regardless of the etiology, and oxygen delivery falls, your oxygen extraction from the blood will increase. But ultimately, you reach a point where the oxygen delivery is so low that oxygen extraction is maximized, and oxygen consumption, which was preserved early on in the shock state, declines. So that we refer to this as delivery-dependent oxygen consumption. And on the left-hand side of the figure here, that's where you, as shock progresses, end up in a state where you're developing end organ dysfunction and metabolic acidosis. So there are 4 primary categories of shock, and we're going to be hearing throughout the week about the many different cardiac etiologies, whether it be an arrhythmia, primary myocardial dysfunction, post-arrest myocardial dysfunction, et cetera. But I can assure you, and you've all seen this in the course of your training, that you will also encounter and be asked to provide care for or consult on patients who have the other forms of shock, such as hypovolemic shock. Typically, this would either be bleeding in the postoperative period or patients with underlying cardiac disease who present with gastroenteritis and dehydration. You can have obstructive shock from a tension pneumothorax, from a pulmonary embolus, cardiac tamponade, or you could have distributive shock, and that could either be in the form of sepsis, or another fairly unique scenario that we sometimes see is the older adolescent who goes to get a ventricular assist device and comes back in a profoundly vasodilated state. So they've got adequate cardiac output, but the systemic vascular resistance is quite low. When thinking about cardiac causes of shock, I want to talk a little bit about the Frank-Starling mechanism. You may have heard about this from Amy earlier this morning, but it's important to just refresh on these concepts because it provides a deeper understanding of some of the treatments that we use to treat patients who are in a low cardiac output state. So if you look, we've got here the left ventricular end diastolic pressure on the x-axis, stroke volume on the y-axis, and a normal Frank-Starling curve looks like this. So the strength Frank-Starling mechanism implies that you can, by increasing your end diastolic pressure or increasing preload, you can recruit additional stroke volume. But in patients who have underlying myocardial dysfunction, the Frank-Starling curve is downward shifted and flattened, such that for a given end diastolic pressure, your stroke volume is going to be substantially reduced. But if you increase preload, either by interventions or by the auto compensation of the patient, as a compensatory mechanism, preload increases, and you can get a somewhat recovery, but not complete recovery of your stroke volume. I also just wanted to briefly touch on the pressure volume loops. So these pressure volume loops depict the relationship between the degree of inotropy you have or systolic function, your stroke volume, and your end diastolic and end systolic volumes. So a normal pressure volume loop is reflected in black here. You can see that during diastole, ventricular volumes will increase. Then with the onset of systole, there'll be a rapid rise in left ventricular pressure until the aortic valve opens. During ejection, your left ventricular volumes will decrease over time. And then once the aortic valve closes, your left ventricular pressure will rapidly decrease and diastole ensues again. So in patients with myocardial dysfunction, primary myocardial dysfunction, you see a couple of things. One, you see a decrease in the slope of the end systolic pressure volume relationship downward here and to the right. You also see both an increase in left ventricular end diastolic volume, right? You've got this compensatory increase in preload that occurs, and you see an increase in your left ventricular end systolic volume and a resultant reduction in your total stroke volume or ejection fraction. So keep these, this Frank-Starling mechanism and these pressure volume loops in mind as we move through the talk, and we're going to refer back to them because some of our treatments are directed at trying to bring these physiologic mechanisms back into a more normal state. So when we think about low cardiac output syndromes, there are two broad categories you consider. One is acutely decompensated heart failure. This is present in patients who have typically a rapid onset in or a change in signs or symptoms of heart failure. These are typically can be a life-threatening condition, requires immediate medical attention, typically in the hospital. And then that can in turn evolve to a state of cardiogenic shock in which you've got systemic hypotension and hypoperfusion. And as I alluded to earlier, you end up with an imbalance in your ratio of oxygen delivery to oxygen consumption. But both of these states, it's important to recognize, are secondary to a decrease in cardiac output despite the presence of elevated intracardiac filling pressures. So another way to think about the pathophysiology of cardiogenic shock is depicted on this figure here. When you've got important myocardial dysfunction leading to a low output state, you'll get this compensatory increase in left ventricular end diastolic pressures. That in turn can result in pulmonary edema and increased work of breathing. That really loads the diaphragm. The diaphragm in patients who have respiratory distress can consume about 50% of your oxygen in the bloodstream. That in turn is going to lead to a state of anaerobic metabolism and metabolic acidosis, which has two effects. One is that can further increase your work of breathing, right? When you've got a metabolic acidosis, you try and compensate by blowing off carbon dioxide. And the acidosis in and of itself can further exacerbate your ventricular dysfunction, and you end up in this vicious circle of cardiogenic shock. So what are the signs and symptoms of low cardiac output syndromes? Well, early on in the process, we often see poor perfusion, complaints of abdominal pain or feeding intolerance, and oliguria. And the reason we see those things earlier is because there's this autoregulation that occurs in the circulatory system to redirect blood flow to the vital organs, which are the brain and the heart, at the expense of providing less blood flow to the mesentery, to the kidneys, and to the skin. Tachycardia and tachypnea are common. As far as blood pressure goes, early on in the process, blood pressure is typically reserved. So if you see hypotension, that's typically a late finding in low cardiac output states. And then finally, mental status changes. We sometimes see this particularly in older patients. And just a quick show of hands, how many of you in the last few years have been called down to the emergency room for a patient who's ultimately found to be in cardiogenic shock, but before you get consulted, the patient's been either had a spinal tap or been sent off to the CT scanner to evaluate for neurologic injury or an intracranial bleed or something like that? Just a quick show of hands. I mean, it seems like the majority of the people in the room have seen that scenario. So the reason this patient's obviously having mental status changes is because there's not enough oxygen and substrate delivery to the brain because they are in shock. The board wants all of us to know about monitoring, and throughout the talk, introduce some concepts of monitoring. For the basic patient who's got decompensated heart failure, obviously hospitalizations indicated, monitoring with telemetry, pulse oximetry, non-invasive blood pressure monitoring, and then typically serial testing with echocardiograms, assessments of electrolytes and renal function, CBC mainly to understand what your hemoglobin level is and your oxygen carrying capacity, and then potentially lactate levels and brain natriuretic peptide levels. But for patients who continue to evolve to a state of shock, then you want to consider additional monitoring with near-infrared spectroscopy, potentially placement in arterial and central venous line so that you can monitor the CVP and mixed venous oxygen saturation levels. When thinking about assessing the cardiac output in patients with shock, it'd be remiss not to discuss the Fick principle. This was first reported by Adolf Fick nearly 150 years ago. Fick was a German physician who first described this concept that you can measure blood flow to an organ if you know a couple of things. One, the organ or the entire body for that matter, if you know a couple variables. One is how much the content of a marker going into that organ is, in this case oxygen, how much of that marker or oxygen is consumed by the organ of the body, and then how much of content of the marker or oxygen is in the venous circulation. And basically describe this relationship that you can calculate cardiac output by dividing your oxygen consumption by the difference between your arterial and venous oxygen content levels. So when you're in the ICU, it's important and very different than the cath lab to know that the use of assumed oxygen consumption is unreliable in critically ill patients. So every year it seems like there's a first-year fellow who wants to tell you exactly what the patient's cardiac output is based on their arterial and venous oxygen saturation levels and the assumed oxygen consumption that they looked up because they just came off of their cath rotation. And I always remind them that the oxygen consumption in a critically ill patient can vary 50 or 60% in either direction from what's reported on those normative tables. So you can't, if you really want to calculate cardiac output in the intensive care unit, you need to measure the oxygen consumption. But that being said, we do look at trends in mixed venous oxygen saturation levels when monitoring patients for low cardiac output states. Ideally, it would be measured from the pulmonary artery, but we rarely have that information in the current era. So the next best alternative would be the superior vena cava, particularly when anatomic endocardiac shunting is present. The normal values would be between 65 and 80%, and a normal arterial venous oxygen saturation difference would be in the 20 to 35% range. So there's no set number that we use to chase or treat, but in general, if values are below 65 to 80%, trending downward, if there's a large arterial venous oxygen saturation difference greater than 35-40%, some form of investigation may be indicated. And as we're going to talk about in more detail, the reason your mixed venous oxygen saturation is going to go down in the ICU is one of two reasons. Either your delivery is decreased or your systemic oxygen consumption has increased. So NIRS monitoring is a non-invasive way of getting a sense, at least, of your systemic oxygenation. NIRS monitors measure regional blood flow oxygen saturation levels using 2 different wavelengths of near-infrared light. The NIRS probes are sampling approximately 1/3 arterial blood and 2/3 venous blood, so it's not truly a mixed venous oxygen saturation level. But people have found, at least in the cardiac ICU, that your cerebral NIRS values have a reasonably good correlation with oxygen saturation levels that are measured from the superior vena cava. So in the postoperative period, studies have been published recently showing associations between declining NIRS values and adverse outcomes. The general rules of thumb would be to investigate or reassess the patient if the regional oxygen saturation levels have changed more than 20% from baseline, if the values are more than 40% lower than your arterial oxygen saturation levels, or the absolute values are less than 50% in the absence of residual intracardiac shunting. So what about lactate as a monitor for low cardiac output states? Just a reminder that lactate comes from pyruvate in states of anaerobic metabolism. So during glycolysis, pyruvate is produced. In aerobic conditions, pyruvate is converted to acetyl-CoA and enters the Krebs cycle, whereas in anaerobic metabolism, so in states of shock, pyruvate can be converted to lactate by lactate dehydrogenase to lactic acid. So there are 2 types of lactic acidosis, a type A lactic acidosis that's due to inadequate systemic oxygen delivery, and that's probably the most common type that we see in the cardiac intensive care unit, but you can also have a type B lactic acidosis that exists when aerobic metabolism is still present, and that it can be caused by an increase in glycolysis that's stimulated by cytokines or either endogenous or exogenous catecholamines. You can produce acid if you have impaired activity of pyruvate dehydrogenase that we sometimes see in patients who've got sepsis, or if you've got important liver dysfunction. So just keep in mind that the liver is responsible for about 70% of the clearance of lactate from the blood. And finally, there's not an absolute level of lactic acid that is necessarily important, but studies by John Sharpey and other folks have demonstrated that the trend in lactate levels over time is probably the most helpful for predicting adverse outcomes. So in terms of low cardiac output syndromes, there are a number of different causes that we're going to be discussing through the week, and I won't read through this list in detail to you, other than to point out that I've listed some of the more common etiologies at the top of the slide and some of the less common etiologies anecdotally that we see in the cardiac intensive care unit down towards the bottom. And the treatment for low cardiac output syndrome, if you want to sort of say focus on one slide from this deck, particularly when you're doing your last minute reviews, this would be it. This is a very busy slide that summarizes all the things that we think about when treating patients with low cardiac output syndrome. I won't read through it, but what we are going to do in the next few minutes is break this down a little bit and talk about different factors that can influence oxygen delivery, and then other things that we can do to manipulate oxygen consumption in these critically ill patients. So when thinking about oxygen delivery, the first thing you want to think about is your arterial oxygen content, and probably the 2 biggest factors that are going to influence that are your hemoglobin levels. So there's not an absolute, hemoglobin of 10, for example, in patients with 2 ventricles, or 15 in patients with single ventricles that we go by, but if you look at the hemoglobin level relative to the patient's current physiologic state as far as a threshold for transfusions. As far as your systemic arterial oxygen saturation levels, if they're suboptimal for the patient's lesion because there's underlying pulmonary disease, providing supplemental oxygen or positive pressure can help bring up your arterial oxygen saturation levels, which in turn, with providing adequate hemoglobin, can optimize your arterial oxygen content. And then as far as cardiac output, we focus on heart rate and stroke volume, and with stroke volume in turn, preload contractility and afterload. So in terms of optimizing the heart rate, right, there's no magic number that we apply to all patients. It has to be individualized. But for some patients, we need to determine if the heart rate is too fast and allowing insufficient diastolic filling. Other patients, particularly neonates who are recovering from cardiac surgery, keep in mind that neonates have a relatively fixed stroke volume, and thus one good way to increase their cardiac output is by providing temporary atrial pacing to increase the heart rate. Obviously, if there's an arrhythmia and you have a lack of AV synchrony, that's going to compromise your cardiac output, and that needs to be evaluated and treated. Keep in mind, when patients are coming back from the operating room, our cardiac surgeons and our anesthesiologists are not electrophysiologists, right? So the pacing settings that they've set up in the operating room may not be appropriate or effective a few hours later once the patient settles into the ICU. So those temporary pacemakers always need to be reevaluated and reassessed early after post-operative admission. In terms of optimizing preload, well, first starting on the right side of the heart, obviously if there's excessive preload, you can have hepatomegaly and ascites. The CVP, again, the absolute value is not important, but depending on the patient's anatomy and expected physiology, the trends over time are certainly helpful. On the left side of the heart, patients with excessive preload can have rales, tachypnea, pulmonary edema on chest X-ray. In terms of looking at preload for both ventricles, one thing you can bank on is pay attention to patient's urine output, and keeping in mind that when looking at your renal perfusion or your urine output and factors that affect kidney function, it's just not your arterial blood pressure, but it's really your renal perfusion pressure, which is calculated by subtracting your CVP from your mean arterial pressure. So a patient, for example, has got a mean arterial pressure of 60. That may be okay if your CVP is 5, but it may not be okay if your CVP is 22 after a Fontan operation. So in terms of treating patients based on manipulation of preload, one of the things we want to do is identify the optimal CVP and pulmonary capillary wedge pressure, or your left atrial pressure, that will optimally recruit stroke volume based on the Frank-Starling mechanism, but without producing systemic or pulmonary edema. Obviously, if the filling pressures are relatively low for that particular patient, giving volume may help improve your stroke volume and cardiac output. But on the converse, if your filling pressures are excessively high and you're kind of tipped over the far end of the Frank-Starling curve, then administration of diuretics and fluid restriction would be appropriate. So what about augmenting contractility? Well, the goal here obviously would to augment your stroke volume at the same or lower end diastolic pressure. So you want to take this abnormal pressure volume loop in the red here and sort of shift it back as far as you can with inotropes to approximate a normal pressure volume loop. And similarly, on the Frank-Starling mechanism, you'd like to get from point B over here closer to point A if possible. So when using inotropes, and I know that I'm not going to go into detail about various inotropes because I know that Dr. McCammon is going to be covering that in a later session, either this afternoon or this week, I believe. But you want to use these judiciously. All inotropes, including milrinone, are known to increase myocardial oxygen consumption. They're all proarrhythmic. If used at high doses, particularly for long periods of time, they can cause myocyte injury and apoptosis. And in adult trials and registries, and there are a number of these have been published, there's a strong association between inotrope use in patients with decompensated heart failure and increased mortality. Those data don't exist in children, but those principles probably apply. So what about afterload? Again, if for a given degree of myocardial dysfunction, an increase in afterload will cause a downward shift and flattening of the Frank-Starling mechanism, and similarly, a reduction in the afterload can improve that Frank-Starling curve for a given left ventricular end diastolic pressure. So afterload is a concept, if you will, that's determined by a number of different factors when thinking about the left ventricle. One is your transmural pressure. There can also be anatomic factors that increase afterload, such as subaortic, aortic, or supravalvular aortic stenosis, or residual coarctation. You can have large vessel impedance if you've got an arteriopathy, or if you've got, for example, a patient with a reconstructed arch that involves prosthetic material that's not going to be compliant. And then obviously your peripheral vascular resistance. So in patients with children with low cardiac output states, your systemic vascular resistance is typically increased in regardless of the primary underlying cause of myocardial dysfunction. So increased SVR is common in cardiogenic shock. It's also very common after cardiac surgery in neonates and infants. And treatment of those patients is generally indicated with vasodilators like milrinone or nitride, for example, or nicardipine. All of those can be used. Keep in mind that sometimes you can have, sort of a low cardiac output state, as I alluded to earlier, in a patient who can, for example, after a ventricular assist device placement, where they can have adequate cardiac output but low SVR. And you need to recognize that those patients are hypotensive because their SVR is low, not because they have a problem with cardiac output, and then you need to treat those patients with appropriate vasopressors. I just wanted to briefly mention the PrimateCorp trial that was published by Tim Hoffman about 15 years ago now, but this was a sort of a landmark trial in pediatric cardiac intensive care in which these investigators randomized patients who were undergoing complex two ventricular repairs to either receive a placebo, low dose, or high dose milrinone. And as you can see here that when compared to placebo, patients who received high dose milrinone infusions empirically that were started just after admission to the intensive care unit had a reduction in low cardiac output syndrome following cardiac surgery. I'll note that all the patients in this trial underwent two ventricular repairs. There are no data for Norwood operations of the patients with the bidirectional Glenn and single ventricle physiology. We actually did study milrinone as a part of a trial that also involved an investigation of nasiratide for empiric use after the Fontan operation while I was in Boston, and found that when compared to placebo, neither of those drugs, milrinone or nasiratide, had an improvement in any of the markers we looked at in the early postoperative period. So we've been talking about increasing oxygen delivery, but what about decreasing oxygen consumption? Well, there are a number of things you can do. As I alluded to earlier, positive pressure ventilation can be helpful. Again, the diaphragm, when patients have increased work of breathing, can consume up to 50% of your global oxygen consumption. So if you can offload that diaphragm and those intercostal muscles by instituting mechanical ventilation, that can be very helpful in terms of getting that balance between delivery and consumption back in line. Sedation, analgesia, and paralysis occasionally can be helpful. I think that the temperature control is one of the things that's really underutilized in cardiac intensive care. If you look at this figure here that shows the relationship between temperature on the x-axis and oxygen consumption on the y-axis, and the temperatures that we're used to seeing, between 35 and 40 in the intensive care unit degrees Celsius, there's a fairly steep relationship between increasing temperature and oxygen consumption, such that for every degree Celsius that your temperature is increased, you've got a 10% increase in global oxygen consumption. So think about that. If you're able to take somebody's temperature down even from 37 degrees, right, which is not considered a fever by any means, to 36 degrees, you can reduce their oxygen consumption globally by 10%. That's going to go a long way towards getting that balance between delivery and consumption back in line. So that's not something that's probably not going to show up on your exam, but anecdotally has been a very helpful strategy for managing patients with a low cardiac output state. At the myocardial level, you also want to do what you can to decrease myocardial oxygen consumption. You can do that by controlling the heart rate, making sure the heart rate's not excessive, by reducing your filling pressures, by the use of fluid restriction and diuretics, and then by manipulating afterload, as we just discussed. So a little bit more about mechanical ventilation in patients with low cardiac output states. We've talked about the respiratory muscle load in the diaphragm quite a bit already. Obviously, if you've got problems with pulmonary edema or a pulmonary infection in a patient with decompensated heart failure, positive pressure and mechanical ventilation can serve to optimize your oxygenation and ventilation. If you've got a respiratory acidosis, you can correct that. That will decrease your systemic oxygen consumption. Facilitates the use of invasive procedures. And importantly, we're going to talk about this in a little bit more detail, if you've got elevated left ventricular wall stress, which you will have in low cardiac output states, mechanical ventilation and positive pressure can reduce your left ventricular transmural wall pressure. So thinking about wall stress is influenced by a number of factors. One is your interventricular pressure, and then the radius of your ventricular chamber, and then that relationship can be reduced by increasing wall thickness. But we're obviously not going to be in the business of manipulating wall thickness in the ICU. We can't control that. We talked about radius of the ventricle, and we can manipulate that by diuresing, providing diuresis. But in terms of our wall pressure, transmural wall pressure is calculated by subtracting your interthoracic pressure from your left ventricular pressure. So if you look at these schematics here, the first one, like all of us sitting here now, are quietly breathing. If our left ventricular pressure is 100, for example, millimeters of mercury, and you're quietly breathing, your interthoracic pressure is going to be close to 0. So your transmural wall pressure will be approximately 100. If, on the other hand, we instituted positive pressure ventilation with a mean airway pressure of 20, which is a bit excessive, but I use that for just to create this example, you would subtract 100 minus 20, your transmural wall pressure would be 80. So instituting positive pressure ventilation directly reduces your transmural wall pressure and effectively reduces your left ventricular wall stress and thereby reduces afterload. A very important concept. Now, in contrast, if you've got obstructive sleep apnea, or you've got a patient who's got ventricular dysfunction who's then extubated and has significant post-extubation stridor and upper airway obstruction, and they generate a negative interthoracic pressure of, say, minus 25, that's going to substantially increase your transmural wall pressure and your left ventricular afterload. So that's not a good situation to be in. If you've got a marginal patient, you're trying to see if you can get them off positive pressure ventilation with important myocardial dysfunction, and then you develop upper airway obstruction, because you probably have a low threshold for either quickly treating that airway obstruction or reintubating that patient because their wall stress in that state is going to be excessively elevated. So how many of you have had experience intubating a pediatric cardiac patient who's in a low cardiac output state? And I would venture to guess, particularly during your first year of fellowship, probably the biggest thing that was on your mind is, am I going to be able to put this endotracheal tube through the patient's vocal cords? And that's certainly something that I worry about and focus on, but there are about 10 other things that I'm thinking about before, during, and immediately after that intubation to keep that patient hemodynamically stable. One, I know that the sedation we administer is going to blunt endogenous catecholamines and also drop ventricular preload, which may lead to further myocardial depression and hypotension. I know that once the patient is converted to positive pressure ventilation, the right ventricular preload is going to drop. If the fellow, and I think I can pick on the fellows because most of you have graduated now, if the fellow's got the laryngoscope in there for an extended period of time, it can induce a vagal response that causes bradycardia. Some of these patients with elevated left atrial pressure, as soon as they're given sedation and a muscle relaxant, they'll start frothing pulmonary edema from the endotracheal tube, which is going to obscure your visualization of the vocal cords. If they got baseline elevated PVR, like an advanced long-standing heart failure patients, they could have a pulmonary hypertensive crisis. And then finally, the coronary perfusion could be compromised, right? If you've got a given diastolic blood pressure and you're going to have a certain amount of coronary flow if your left ventricular end diastolic pressure is only 5, but a patient with advanced heart failure who's got a LV EDP of 25 is going to have much more limited coronary flow and coronary flow reserve. So any degree of hypotension, further hypotension during that intubation could lead to relative coronary ischemia and bradycardia. So obviously these patients are at high risk of cardiac arrest. You need a very experienced team to put these patients to sleep for intubation. You want to be cautious about the induction agents you choose. Agents like fentanyl, for example, are more hemodynamically stable than morphine or Versed. You may even want to pre-medicate the patient with a catecholamine infusion, like a dopamine drip or epinephrine infusion. Even though they've got heart failure and elevated filling pressures, because of the transition to positive pressure and because of your induction agents, you may need to augment preload, so you need to be ready to do that. And then finally, you need to consider whether the patient would be a candidate for ECMO and ECPR, and if so, have your surgical teams available and ready to cannulate if necessary. So I've summarized some of the concepts that we've talked about at low cardiac output. I'm not going to read through this slide carefully, but this may be a good sort of last-minute reference for you before the examination. So we're going to switch gears a little bit and talk about cardiopulmonary resuscitation. There's a recent study that was published in Critical Care Medicine that nicely showed that the rate of cardiac arrest in children with cardiac disease who are in intensive care units is roughly 4-fold higher than the rate of cardiac arrest in pediatric patients who are cared in those same ICUs who do not have underlying cardiac disease. Fortunately, the survival to hospital discharge rates, well, not great, or relatively the same between the two groups. I think in preparation for the boards, one of the important things to do would either be to get out your most recent PALS booklet or look at these two most recent guidelines from the American Heart Association regarding cardiopulmonary resuscitation in children. And these are both somewhat lengthy documents, but at least if you reviewed the key figures that were in there about the management of cardiac arrest algorithms for tachyarrhythmias, bradyarrhythmias, pulses, VT, VTAC, et cetera, I think that'll go a long way towards addressing some of the questions you may face and some of the clinical scenarios that you're going to be dealing with in the years to come. It's important to understand how CPR, chest compressions actually work. There's obviously direct cardiac compression, but you also need to understand the thoracic pump mechanism. And there's two sort of components to this. The first is that there's a compression-induced increase in interthoracic pressure, aside from the pressure that you put on the ventricle per se, that leads to ejection of blood from the thorax out to the peripheral circulation. But when you, the recoil of the chest after you compress it generates negative interthoracic pressure, which promotes systemic venous return into the thoracic cavity. So that's why it's very important when you're in your PALS cast and they talk about making sure you don't continue to lean on the chest if you're tired, to allow the chest to fully recoil, to augment that thoracic pump mechanism and augment systemic venous return back into the thorax. We tend to think of cardiac arrest in 4 phases. The first is the pre-arrest phase, where monitoring, rapid response are important, and treatment of respiratory failure and shock states are important to prevent cardiac arrest. There's a big initiative ongoing now for those of you who are in centers that are involved in the Pediatric Cardiac Critical Care Consortium about identifying patients at high risk for cardiac arrest based on empiric data from the clinical registry. And then we've developed a bundle to implement for each of those patients with a multidisciplinary team to try and minimize the occurrence of cardiac arrest in our pediatric cardiac ICUs. So that this multi-center quality improvement collaborative has just been kicked off in recent months, and I suspect it'll be a year or two before we see the outcome data for this bundle, but I suspect you'll be hearing about that in the future. During the arrest phase, you want to minimize the interval to onset of resuscitation, and if indicated, minimize the interval to defibrillation. During CPR, push hard, push fast, allow full chest recoil, as we just discussed, minimize interruptions to compressions, which will compromise your coronary blood flow. Avoid overventilation. People are nervous, and they want to tend to respiratory therapist or whoever's got their hand on the anesthesia bag tends to want to hyperventilate the patient. That's not good because that positive interthoracic pressure can compromise systemic venous return. And as we discussed earlier, consider early activation of ECMO for the right patient in the right setting. In the post-resuscitation phase, you need to pay attention to cardiac output. There's often myocardial stunning. You want to target a systolic blood pressure at least the 5th percentile for age, treat any arrhythmias, avoid hyperglycemia, hyperthermia. We'll talk about that more in a second, and as well as hyper and hypoventilation. You need to target normoxemia, so you don't want the patient to be hypoxic, but at the same time, you don't want their PO2s to be 400 or 500 because that can have adverse effects on long-term central nervous system outcomes. Last year, the multi-center THAPCA trial was published. This was a multi-center randomized trial in which patients were randomized to either receive children who were in the hospital and experienced a cardiac arrest were randomized to either receive hypothermia down to 33 degrees for 48 hours or normothermia at 36.8 degrees as the target temperature. And in this large multi-center trial, there was no difference in primary or secondary outcomes with the use of hypothermia. So the current HA guidelines, which were published in 2015, recommend either 5 days of normothermia or 2 days of hypothermia, followed by 3 days of normothermia for children who experience a cardiac arrest. I'm not sure if those guidelines will be revised based on these trial data or not, but right now I think the most important thing is to avoid the development of fever early after cardiac arrest in order to optimize CNS outcomes. I think what I'm going to do for the sake of time, the next few slides are about different types of end organ injury that can develop in terms of AKI, renal failure, and the different forms of renal replacement therapy. I intentionally organized these slides so that you could flip through them on your own if we didn't have time to cover them during this session, because I really want to get to the questions at hand. There's a couple of slides in here about necrotizing enterocolitis that are fairly self-explanatory and worth reviewing, including this particular table here about the different signs of NEC, the radiographic signs, and the recommended treatments. I know that Amy McCammon is also going to be talking to you about thrombotic complications and anticoagulation, so I specifically am not going to touch on that in my two talks. There is a nice summary slide in here about heparin-induced thrombocytopenia that's worth reviewing on your when you have a moment. So why don't we stop there for a moment, and then I thought what I would do is cover a couple of the practice questions that I'd submitted that will touch on some of these concepts that we've just discussed. So the first question, you've got a 6-year-old patient with dilated cardiomyopathy who develops ventricular fibrillation. Following Powell's guidelines, chest compressions were started, and the first attempt of defibrillation with 2 joules per kilo is being performed when you arrive at the bedside. Ventricular fibrillation, however, persists after that first shock was delivered. A chest X-ray obtained a few minutes before the code is shown in the figure. So which of the following is the best answer? A, resume CPR and administer IV amiodarone 5 milligrams per kilo. B, resume CPR and give IV epinephrine 10 mics per kilo. C, resume CPR, perform a second defibrillation with 4 joules per kilo approximately 2 minutes later. D, resume CPR and perform a second defibrillation with 2 joules per kilo approximately 2 minutes later. Or E, resume CPR and prepare for ECMO cannulation. So let's see, this is obviously testing your knowledge of the Powell's guidelines. And this would be if I was writing questions for the exam, which I'm not, I would put something on there about the management of pediatric cardiac arrest. So most of you, the majority of you at least said C, which is the correct answer, to resume CPR and perform a second defibrillation of 4 joules per kilo approximately 2 minutes later. That's what's recommended by the Powell's guidelines. Epinephrine is typically not recommended until after the second defibrillation in this scenario, and amiodarone or lidocaine, which would also be acceptable, would be a acceptable intervention after the third attempt at defibrillation. And then second and subsequent shocks are at least 4 joules per kilo. That's why answer D is wrong. And option E, I think it's a good idea to activate the ECMO team early in the process for a patient like this, but you wouldn't necessarily want to cannulate until you made further efforts to address the arrhythmia. There's a question. Go ahead.
As intentionally placed.
So I'm glad you picked that up. So I had previously written this as a trick question, and I didn't think it was appropriate to try and stump you guys. But why don't you tell everybody what concept that you're alluding to on there? What's the problem with this chest X-ray?
Oh yeah, so the pad on the apex should be on the left side, unless there was extracardia. The sternal pad seems to be appropriately placed, or it could be front and back.
Right, so the concept here is that you want the energy vector from the pads to go through the myocardium that you're targeting. And the reason I had this slide here, and it wasn't this particular patient, but I've seen a patient develop a treatable VF from hyperkalemia after cardiac surgery, and the pads were malpositioned. The fellow shouldn't say that, I keep picking on the fellows, but it is always the fellows. No, but the team at the bedside thought the patient had dextrocardia when he didn't, and put the pads like this, and the patient actually had levocardia and was unable to be resuscitated, and had already been on ECMO once and ended up not doing well. And I've also seen patients who've got HOA arrhythmias come from outside hospitals where the pads are placed in the usual position, right, the left apex and right upper sternal border, but the patient's in atrial tachycardia, and they've got burns on their chest for so many attempts at cardioversion. When you think about it, the atrial mass is way back by the esophagus, and you can easily cardiovert patients like that if you put the pads anterior or posterior and deliver a relatively low dose of energy. So the pads, I'm glad somebody picked up on that. I was going to make that teaching point if needed. All right, if nobody called me on it, but good pickup. All right, second question. Which of the following will increase left ventricular wall stress in a child with acutely decompensated heart failure? A, the Valsalva maneuver, B, upper airway obstruction, C, positive pressure ventilation, D, BiPAP, or E, a nitroprusside infusion? All right, most of you got that one. The correct answer is B, upper airway obstruction. So all of the other interventions will decrease your left ventricular wall stress. And then the final question for the moment. An infant with unrepaired tetralogy of Fallot and severe pulmonary stenosis is intubated. A chest x-ray revealed relatively dark lung fields. Your arterial blood gas is 739, PA CO2 40, PO2 30. At the time the blood gas was obtained, the end-tidal CO2 monitor was reading 25 millimeters of mercury. What's the most likely explanation for the discrepancy between the PA CO2 and the end-tidal CO2? A, large PE, B, hyperventilation, C, increased dead space ventilation, D, decreased carbon dioxide production following intubation and sedation, or E, esophageal intubation. This is testing your understanding of end-tidal CO2 monitoring in intubated patients, which is one of the target areas listed on the ABP content outline. So let's see. And most of you got this correct. The correct answer is in fact C. So if you had a large pulmonary embolus, both your PaCO2 and your end-tidal CO2 would be elevated. If you were hyperventilating, both levels would be, your PaCO2 and your end-tidal CO2 would be low. If you had decreased CO2 production, that wouldn't explain the delta between the two. And if you had esophageal intubation, your blood gas arterial CO2 would be quite high, and your end-tidal CO2 would presumably read 0. And then the question is, why do you have increased dead space ventilation? And that's because you've got carbon dioxide-rich systemic venous return coming back to the heart, shunning right to left through the VSD and back out into the arterial circulation. So your arterial CO2 is higher than your end-tidal CO2. So we commonly see that in patients with intercardiac mixing and shunning, where the end-tidal CO2 is 10, 15 points lower than your PaCO2 on a blood gas.
Full-term baby has ductal-dependent congenital heart disease and is receiving prostaglandins of the following types of critical congenital heart disease. For which lesion would the risk of a neck would be lowest? A, VSD with interrupted arch. B, hypoplastic left heart syndrome. C, pulmonary atresia with intact ventricular septum. D, critical aortic stenosis. E, critical coarctation of the aorta. So of all these lesions, which one does not give you a higher risk of neck? Excellent. So there's data from many centers now that there is possible to have neck with pulmonary atresia and a big duct. It's possible, but it's less likely than any of the left-sided lesions that are ductal dependent. Question number 5. A 60-year-old with fulminant myocarditis experienced a 20-minute cardiac arrest based on 2015 AHA guidelines. Those guidelines that Dr. Costello put up, the most reasonable parameters for post-arrest targets for the next 3 days are A, Temperature of 37 to 38.5 with systolic blood pressures of 80 millimeters of mercury and PaO2s of 300, PCO2s of 40. B, temperature of 37 to 38.5, systolic blood pressures of 70, PaO2 of 100, PCO2 of 40. C, temperature of 36 to 37.5 with systolic blood pressures of 80, PaO2s of 100, PCO2s of 40. And D, temperature of 32 to 34, systolic blood pressures of higher than 80, PaO2 of about 100, and PCO2s 25 to 30. And last, temperature of 32 to 34 with systolic blood pressures of 70, PaO2 around 100, and PCO2 of 50. What are the parameters you aim for after cardiac arrest? Choose your answer. So the right answer is keeping the patient euthermic, not hyperoxygenated, not hypercarbic, and hopefully normotensive. And all the other ones have either higher temperatures, lower CO2s, or hyperoxia. So this is from all the choices that were there from A to E, this is the one that is the best choice. There are a few of you who answered D, and that, although it's cooling, also is aiming for a PCO2 that is lower than normal. And in E also is cooling with CO2s that are higher than normal, so also that one will be incorrect. So the following are the most consistent with HIT or heparin-induced thrombocytopenia. Which of the following is the best answer? A, 10-day-old neonate with hypoplastic left heart syndrome on ECMO with platelet count of 60,000 per microliter. B, 5-month-old cytosposed elective VSD repair now postoperative day 2 with platelet count of 90,000. C, 5-month-old cytosposed elective VSD repair now postoperative day number 8 with platelet count of 10,000 and active bleeding. D, 5-year-old postoperative day 5 following Fontan operation with platelet count of 45,000 and clot in Fontan pathway. And E, 6-month-old with Kawasaki disease and known giant coronary artery aneurysms on low molecular weight heparin admitted to the ICU from clinic with a clot on the LAD and platelet count of 200,000. So of all these clinical pictures, which one is the most consistent with HIT? Please choose your answer. Interesting. That's good. Well, one of the issues with HIT is that it's a time-sensitive diagnosis. So it's unlikely that you're going to get HIT immediately after an operation. It's going to take a few days. Also, you require some previous exposure to heparin. So if it's the first time you ever had heparin, you're unlikely to get it. So the patient of all this who is more likely to get HIT is a 5-year-old who is a few days after a Fontan operation, who's been previously exposed to heparin and now has a platelet count that's less than 50,000 and a clot in the Fontan pathway. Usually HIT presents as a phenomenon of thrombosis and bleeding at the same time.